Cloud.
Now it's recording.
Gotcha.
Yeah, and panelists, feel free, even encouraged to text comments or questions into the chat. It sets a good example for everybody else as well.
And the chat will be saved, right? And we'll know who everyone is because they have to register, correct?
Yes.
Correct.
For all of those, all you people already online, we'll be starting in a minute. Good afternoon, everyone. I'd like to welcome you all to the bi-monthly webinar of the Geriatric Emergency Department Collaborative. My name is Dawn Milady. I'm an emergency physician at Mount Sinai Hospital in Toronto, and I'm a faculty member with the Geriatric Emergency Department Collaborative, the GEDC. Today's webinar is on the topic that is at the front of everyone's minds, the COVID-19 pandemic, and specifically its impact on the care of older people in emergency departments around North America and around the world. The Geriatric ED Collaborative is a project generously funded by the Gary and Mary West Foundation and the John A. Hartford Foundation. Our goal is to educate ED clinicians about models of care to improve care for older people in emergency departments. We also support emergency departments and health systems to implement those models of care. And we're involved actively in research to evaluate the outcomes. For this webinar, continuing professional development credits are offered by the American College of Emergency Physicians. Participants will be contacted in 7 days to register for those credits. That's the reason your registration material was asked for when you logged in. Before I introduce our panelists, I want to ensure that you can all use the Zoom platform. All of your microphones have been muted, and I suggest that for the panelists, when you're not speaking, to also mute yours. But we do want to hear from all of you, your comments and your questions. And the best way to do that is through using the chat option. To find the chat box, follow these instructions. Hover your mouse over the screen and you will see the 5 icons at the middle bottom of the screen. Click on chat. I'd suggest that you leave it open through the whole presentation so that you can keep track of other people's comments and questions. Today's webinar is being recorded, and the link for the recording and the slides will be sent to all registrants later today. And as we get started, can I just suggest an exercise? I'd like you all to enter into the chat box where you're calling in from. I think we've got many states, many provinces, and many countries represented. So text in where you're calling in from. And also, if you have a specific question or a comment or something in particular that you want to hear about, please let us know and we'll try to address that. Today's webinar will be in 3 parts, and we've assembled an excellent panel. First, we want to review some of the key points that you need to know about older emergency department patients during this COVID pandemic. This will be presented by the authors of a recent paper on just this topic, which is available on the Geriatric ED Collaborative website. Dr. Michael Malone is a geriatrician with the Advocate Aurora Health System in Wisconsin. Dr. Tess Hogan is an emergency physician at the University of Chicago. Dr. Adam Perry is both a geriatrician and an emergency physician in community practice in Pennsylvania. They are all faculty members with the Geriatric ED Collaborative. The second part of the webinar, we want to address some of the critical care issues that we all need to learn to provide care to older patients during COVID-19. This will be presented by Dr. Kusum Mathews, who is an intensive care physician at the ICANN School of Medicine, Mount Sinai, New York City. She was one of the first dedicated COVID ICU attendings and probably has as much experience as anyone in the critical care of older COVID-19 patients. If you want to learn more than she's able to present in her 15 minutes, please check out the excellent podcast she did on GEMcast. That's Geriatric Emergency Medicine Cast, GEMcast. Third, we want to address the important issue of critical conversations, advanced care planning, and symptom management in end-of-life care in general, and as it relates to the ED and older COVID-19 patients. This will be presented by Dr. Martine Sanon from the Department of Geriatrics and Palliative Medicine, also at the ICANN School of Mount Sinai, New York. Dr. Sanon is also a member of the Geriatric ED Collaborative. Ideally, we'll have about 10 minutes at the end to answer questions that arise. So I'll now turn the presentation over to Drs. Malone, Hogan, and Perry.
Thank you, Don. One of the things that we wanted to point out is that this particular illness called COVID-19 has some specific nuances where it disproportionately affects older adults, and especially those with chronic diseases or disabilities. So we took this situation and really tried to write about the particular needs of older adults, particularly in the context of emergency departments, and as they either are considered for transfer to emergency departments and or receive care in the emergency departments. So on the GEDC website, we wrote about and posted this paper in this new Journal of Geriatric Emergency Medicine describing the multiple facets and needs of our patients in our communities. Next slide. We also, over the last 2 weeks, have had the opportunity to really understand and study the unique needs of older adults as they present to the emergency department with COVID-19 and their particular risk for developing delirium and how to prevent such and manage such, in the emergency department. And then, so thanks to Eula Wang and her colleagues for developing this piece. And then likewise, Dr. Stacy Levine from University of Chicago led another group that really looked at the unique needs of older adults as they are transferred between skilled nursing facilities and emergency departments, hospitals. And this was likewise released at the latter part of last week. Amazing opportunities to study further the unique needs of older adults. Next slide. So one of the things that we looked at in regards to older adults in the emergency departments is that those older adults who develop symptoms with COVID-19, they seem to be at particular high risk. And what we tried to look at was a number of different needs in regards to their care transitions, their needs in regards to their clinical presentation, and a number of different needs, especially those who perhaps have Alzheimer's disease and other common conditions of aging. So we tried to describe this and outline them in this paper. Next slide, please. I think a couple themes. So while the prevalence of COVID-19 presentation is, I'll say, escalating, when we started writing this paper, there were 2,000 cases in America and 50 deaths. And as of today, 144,000 cases and over 2,500 deaths. There are specific needs that we need to understand in regards to vulnerable older adults, particularly those who have perhaps behavioral health needs, functional impairment, cognitive impairment, as they, let's say, receive care for and develop perhaps morbidities from this illness. What you'll see is a number of different comments in regards to atypical presentation. Many of these are not featured on the CDC website and may include that the older adult may not develop a fever, they may be tachypnic, they may have delirium, they may have unexplained tachycardia, perhaps a drop in their blood pressure, perhaps muscle aches. You'll hear more from Dr. Mathews in regards to such presentations. I'm also struck by the unique vulnerabilities of working with these individuals in that it's hard to really communicate with them because of all of the personal protective equipment. There's also multiple needs as individuals receive care from assisted living facilities, skilled nursing facilities, and such, and community. And there's a number of nuances in the transitions back and forth from these settings. We'll encourage you to understand this carefully and to look both at the CDC website and at a paper from Dr. Stacy Levine and her group that describe many nuances of this. And then finally, we'd like you to really understand that this is a vulnerable situation that puts strain on families and on family caregivers, and that we would like you to make sure that you take into account the special needs of family caregivers as their loved ones receive care during this condition. I'd like to introduce Dr. Tess Hogan, who'll take it further. You're on mute, and Tess, you might be on mute.
Thank you. Good afternoon. One of the things that I wanted to discuss, as Mike stated, the data is extremely variable, but what I wanted to keep in mind are the data that keep us moving in the right direction and keep us alert to the right things. When we started the collaborative years ago, it was to address the needs of vulnerable older adults who often slip under the cracks in our healthcare system, and especially in our busy emergency departments. And this is all the more so today when we are under pandemic conditions and everyone is struggling just to do the right thing at the right time. Those most frail among us are the first that we are ignoring. So keep them foremost in your mind. As you look at this data, I liked this slide in particular because it gave us some kind of a hinge to focus on, and that is the familiar theme of influenza. So if you look at influenza versus COVID, the mortality rate in influenza increases by decade as it does with COVID, but the numbers are just logarithmically different. This data from South Korea, which we believe is very reliable data, shows about 8.2% mortality rate in those older adults over the age of 80. Next slide, please. To look at how different data is from different countries, the same parallel between influenza and COVID stands, where influenza, it increases by age but doesn't affect nearly as many or kill nearly as many older adults. Here, the data shows older adults greater than 80, about 14.8% of them are dying with the disease. The hopeful thing in this slide is that over 85% of 80-year-old patients with COVID are surviving the disease. So although it is a very dangerous disease and more dangerous for older adults, it is not a death sentence. And I think we need to be very careful to communicate that to our patients, their families, and to our colleagues. So the severity of disease, the incidence of hospitalization, admissions to ICU, and death all increase by decade, but they are not a death sentence. The higher case rate among older Americans strongly suggests that a true underlying biologic vulnerability exists in older adults, probably exacerbated by existing illnesses that sharply increase both the risk of the infection itself as well as the infection becoming severe. The important thing also to keep in mind is that these numbers change as testing increases. So the numbers that I have just shown you are not true fatality rates, because true fatality is the proportion of those infected who die, not the deaths in identified positive cases. And all the data that we have seen to date is simply deaths from identified positive cases. Next slide, please. So the other thing that is clear is that different pre-existing conditions have different or convey different increased risks, and the highest risk group to date are those people with heart disease, followed by diabetes, and then chronic respiratory illnesses, and you can see the rest there, most of which do affect our older adults. So we need to increase testing to properly define the scale of the epidemic. Only then can we make measures focused on older populations and hospitals that are truly unbiased. It seems that the countries with older populations need more aggressive actions. Demographically informed projections are going to predict the COVID burden and help inform health providers and governments about our targeted actions. Triage needs to improve, and our policymakers are going to need to focus on reducing risks for older adults and people with underlying medical conditions. One of the things we looked at in the nursing home transfer paper was that particularly vulnerable group of individuals and what can be done to assist with their care. Next slide, please. In addition to focusing on our patients, it is also important to recognize that the workforce in medicine has many older individuals themselves. So Older healthcare workers are among those who are also at risk for COVID. And there are many institutions that are providing alternative staffing models so that their older health providers are out of the line of fire. They are treating patients that are less likely to have COVID infections. They are not participating in the high-risk procedures such as intubations. Next slide, please. Also, safety is a very important concern of all of us. As we know, overcrowding disproportionately affects all older adults, and they see the most difficulty in overcrowded emergency departments. The example that I'll give you is over the last 2 years at University of Chicago, we've been trying very hard to do all kinds of things for older adults, including gait testing. That had to fall by the wayside because we cannot be ambulating older adult patients in our hallways where they are at higher risk for catching the illness. The longer people stay in the emergency department, the higher their risk for delirium. Deliriogenic things in the emergency department exist all the time. It's worse now when every provider that you see has their face masked and a face shield, and it's very difficult to hear and understand them. Medication reconciliation is difficult to do under non-crowded circumstances, much worse now. There are all kinds of programs for older adults to help improve their cognition in the emergency department, delay delirium, get them to move around the department. And again, all of those efforts are decreasing in these stressed conditions. The perception of risk and benefit for everything that we do in the emergency department is now changing in light of COVID. So you normally would try to get the older adult to ambulate to the bathroom. You may not be able to do that. Speaking to them about goals of care early on is important, and we're going to have a marvelous presentation on that to follow. So I'd like to now introduce my colleague, Dr. Adam Perry, to continue the talk. Thank you, Adam.
Thanks, Tess. And as you alluded to, there are risks, benefits, and alternatives to the ED have changed drastically in a brief period of time. The picture here is meant to denote a community paramedicine model. And with COVID, many sites around the country have realized before a surge of COVID patients, the EDs have sort of emptied out. And this is in realization of patients selecting their own risk and benefit decisions and kind of shying away from the emergency department. At the same time, policy has changed to really rapidly drive innovation with regard to forward triage and the idea of selecting only those patients that the benefit of the ED outweighs the risks and take into account available resources. So community paramedicine is one. Telehealth, of course, we all know is rapidly increasing. EMS protocols as far as selecting who comes in. And then some facilities and outpatient centers have selected an alternative to the ED in that they can do stat imaging and such that prior they'd have to go through the emergency department to do. And as Tess just mentioned, and we'll hear about later, that advanced care planning, it really is a form of forward triage and deciding on a patient's wishes prior to presentation. Next slide, please. This next slide is really just a word on transitions. With that risk and benefit in mind, any older adult who presents to the emergency department and has decided that that risk is worth it, should they go through one of these triage models, forward triage, or should they self-select? A firm transition, a durable transition is important. This Rockwell picture sort of describes the, if you think like the SNF to ED transition in 6 or 7 handoffs of information from the nurse to the paramedic to the doctors and nurses working in the ER. In the COVID era, potentially it's more valuable to have a warm handoff and 2 discussions between outpatient providers and the ED clinicians, and really building a team around that vulnerable older adult and using the expertise of the outpatient provider that we'll talk about here in a moment to help the ED doc, maybe talk to the family, talk about goals of care. There's some links there that'll be covered in more detail later on. And with that, we'll go on to our next speaker.
I thank you very much, you three. And I would now like to turn this over to Dr. Kusum Mathews from Mount Sinai in New York. Dr. Mathews.
So thank you so much for inviting me to join this fantastic webinar. I'm going to discuss what you need to know and how to help critically ill patients with COVID-19. Now, I'm speaking today from the perspective of someone who's been clinically working through the surge on the inpatient side. But as we get more and more influx of sick patients, I'm hoping that my discussion points will be of use to you in the emergency department setting. So as discussed, the clinical presentation of patients to the ED is not unlike the flu. Patients present with fever, URI symptoms, often productive cough, hypoxemia, fatigue, headache, chest tightness, abdominal pain and diarrhea, and so on. A lot of the information that we have about the symptoms that patients present with COVID-19 is based on what's been published out of China and Italy, but this is not age specific. And as we know, elderly patients may present with more atypical symptoms, especially in absence of fever. I've had several patients who are elderly who just have low-grade temperatures and malaise who are found to be hypoxemic and having that chest tightness. The history is helpful here in terms of COVID sick contacts, but at this point in New York City, honestly, we're just presuming everybody has the potential for sick contacts, and especially if they're coming from facilities in the area. Now, the initial workup that we're doing on all patients includes, can you click please, Laura? Back, sorry. Can you go back? Thank you. Of course, the SARS-CoV-2 PCR, although there is, it's only about 70% sensitive. We do have a clinical suspicion for these cases, and we've actually had to retest some patients. Other infectious disease workup is also very important, which includes cultures, blood and sputum, respiratory DFA, because we've had co-infection with the flu and paraflu, Legionella, procalcitonin, which can help us decide whether or not there's bacterial infection going on. We also need to be checking a troponin, CK, LDH, C-reactive protein, D-dimer, and fibrinogen. A lot of those markers are because of the sequelae associated with COVID-19, and I'll get to that in a little bit. And of course, we have to do chest x-ray because many of these patients have multifocal pneumonia, which will help us triage how quickly they potentially need more supplemental oxygen or even more invasive modalities. Next slide. So the later symptoms, I brought up that initial workup because oftentimes patients have already had COVID symptoms for a week prior to presenting in your emergency department. As such, you may be seeing demand ischemia, transaminitis, acute kidney injury, and then of course, respiratory distress or high work of breathing is very common in this patient population, especially in the elderly, and of course, there's a high risk for moderate to severe acute respiratory distress syndrome. Next slide. So what we have at our disposal is standard care ventilator options, but these have to be tailored for COVID-19. As I mentioned, these patients are presenting with hypoxemic respiratory failure. In fact, it's estimated about 20% of all COVID patients will fall into this category, with about 14% requiring supplemental oxygen and 5% of all comers requiring ICU admission and mechanical ventilation. So if we're looking at our COVID patient, next, we're trying to use we're using the SECM guidelines that were just published about a week ago, and we're preferentially using nasal cannula up to about 6 liters per minute on these patients. And then if for their work of breathing and for their oxygenation, transitioning them to 100% non-rebreather if we need to. We are trying to avoid Venturi masks or face masks because of the risk of aerosolization with humidification. Again, this is all about reducing exposure to surrounding patients as well as to healthcare workers. Also a change for us in about the last week because of the SECM guidelines, we are now using high flow nasal cannula as well as non-invasive ventilation BiPAP on these patients. Now, ideally, those two modalities are done in a negative pressure setting, which is of course limited in our emergency departments. And the key thing is for the BiPAP, we want to avoid overventilation. These patients, as they're very compliant lungs and they're in respiratory distress, there's going to be large swings in their volumes and large swings in their pressure, which puts them at increased risk for patient-induced lung injury and puts them on the further down the pathway toward ARDS. Next slide. So what do we have in terms of ventilation options? Well, if the patient's decompensating, of course, we're going to have to intubate them. Next. What the recommendations are, and this is what we've been doing at our shop, is to do pre-oxygenation with a non-rebreather. Again, avoiding bag mask ventilation at all costs. Again, to avoid the aerosolization of these procedures. To do rapid sequence intubation with video laryngoscopy. Again, we're trying to create as much distance as we can between the person who's intubating and the patient, who is, of course, filled with droplets of COVID. But the reality is whatever modality you're most comfortable with intubating, that's what you should be doing, because ideally it's done as quickly as possible. And if needed, and we have patients with concurrent asthma and other things, if you're going to use albuterol or Atrovent or any of the other medications, one of the things to do is try to use it with an MDI as opposed to a nebulizer, again, to avoid aerosolization. Next. Now, we also have adjunct care at our disposal. Next. That we should be thinking about are heavy sedation, which of course puts us at increased risk for delirium in our elderly patients. And these patients have a lot of venous synchrony. So using early use of neuromuscular blockade is often necessary. So these are just boluses ideally until you get them sedated, with sedation of course, and then you may even have to start them on a continuous infusion of neuromuscular blockade. As I mentioned, up to 10%, if not higher, of these patients end up having a co-infection. So we are recommending antibiotics as well as early sepsis care, although be judicious with these fluids as these patients have a tendency for capillary leak. And of course, that means they're going to be on the ventilator longer. And of course, unfortunately, because they are critically ill, you may need to use vasopressors. Now, I bring up all this adjunct care because unfortunately, as we move forward with more and more surge in all of our facilities, the ICU beds, the inpatient beds are going to become more and more rare. And you may end up having to manage these patients longer in the emergency department. Next. And so that brings us to the idea of triage decisions. Next. When we're thinking about whether or not to intubate patients, we have to consider their baseline pulmonary disease. Maybe it's someone who you know is not going to do well in that trial of high flow or BiPAP, and so you want to actually move quickly into intubation for them. But you also have to consider the other comorbidities and what are the available resources to you in terms of ventilators. And I'm going to talk about that in a little bit as well. But the reality is this should help to shape your conversations with your patients and your decision making around what modality to use, because you want to see how long they're going to be on the ventilator. In Italy, it's about 10 to 12 days these patients are staying on the ventilator. And so you have to take into consideration when you're making that decision, what's the likelihood they're going to get off that ventilator. Next. So I was asked to give some general recommendations as to like, what are you going to do post-intubation management? Because again, you're intubating them, you have to put them on a ventilator right away. What are you going to do? It's standard ARDS management for a lot of it. It is low tidal volume ventilation. Next. With a volume control mode. And ideally, you want to use 4 to 8 cc's per kilo of ideal body weight. If you don't have a tape measure, you don't have a pre-recorded height, aim for about 400 cc's for a woman and about 450 for a short male, about 500 for someone who's taller. These patients also benefit from higher PEEP, so starting setting, I would recommend 8 to 10 for their PEEP settings, and then of course titrate up the FiO2 as needed. I mean, these patients, especially for the obese patients, really do benefit from higher PEEP. And then of course it's standard ARDS and sepsis management, and unfortunately that's a lot of stuff that you may end up having to do in your emergency department until they can move upstairs. Now there is some institutions, including our own, that are using off-label use of certain medications like hydroxychloroquine and azithromycin, as well as antivirals and anti-IL-6 agents. And I won't talk about too much of those medications because the evidence for its use are limited. And I think people are just trying whatever they can to help these patients. But if you do choose to use especially the hydroxychloroquine and the azithromycin, please check a QTC. And then of course there are clinical trials being rolled out for multiple agents right now all across this country. So I'm hoping we do get some definitive answers about what we can do. There's also compassionate use of convalescent plasma that's being used. So anybody who's survived the illness and recovered a few weeks afterward, we're asking them to donate their plasma and trying to infuse these antibodies into sicker patients to see if we can help them recover. Next slide. So what are the frontline realities? What are the things that you need to be considering in the ED? Next, if you are hopefully before surge, you're thinking about isolation. Next. And ideally, it's a separate section in the emergency department to reduce patient exposure and to hopefully reduce healthcare worker exposure as well. We want to have negative pressure for any aerosolizing procedures, or at least try to move them into a certain negative pressure room when you're having to intubate them. And then every shop should have plans for surge, because if it hasn't hit you yet, unfortunately, it very well may. Next. And of course, PPE. This is something that's all over the media as well as social media. Ideally, your institution should be very transparent about the policies for face masks, face shields, N95 and surgical masks, as well as the use of gowns. We're doing extended use and reuse planning, recycling of these N95 masks, and then of course making sure that everybody has very, very high level of comfort with don and doffing. Next. And we have to talk about staffing, because unfortunately staffing is a very limited resource. We're asking for people to come to New York who have intensivist backgrounds. That includes our emergency physicians to help us work and staff the different parts of the hospital. But we need to think about also protecting our healthcare workers, including minimizing exposure. You know, one of the other speakers talked about protecting the older physicians, and doing telehealth is one of the things that we've actually been doing here at Sinai. We also need to be thinking about how we're going to involve our trainees and the support staff in this. And originally, we weren't having any of the trainees that even examine the patients, let alone do any of the aerosolizing procedures like intubation. As we get more and more limited in our healthcare workers in terms of the ratios from physician to patient, this has become limited. So now the trainees are helping us out with procedures and having to do intubations too, just because we don't have another choice. But again, we need to also plan for illness and surge. The numbers are about 20 to 40% of all healthcare workers will either be sidelined because of they themselves have COVID-19 or one of their loved ones. So this is something you guys also have to take into consideration. Next. And then of course, last is the ventilators. As I mentioned, there's going to be more boarding of these patients in the emergency department. So if ideally get trained up on ongoing vent management. There's a lot of resources out there, including at SCCM, on how to manage the ventilators. I'm hoping Connor can send some links for some infographics on, and as well as the links will be in our slides to some good training resources in case you want to review. But we also have to consider, well, who are we going to give the ventilator to? And vent splitting is something that we've also approved here in New York, and maybe something that happens elsewhere as well, where we're actually having more than one patient on one ventilator. This all brings up the idea of, should we be having goals of care conversations before we intubate? And if so, in what way? And with that, I will say thank you, and hopefully this is a good transition to Martine's talk, which will talk about how we can actually do the goals of care questions effectively.
Good, thank you very much, Dr. Mathews. And with that, we'll turn it over to Dr. Sanon, also from the Mount Sinai, New York. Martine?
Hi, good afternoon, everyone, and thank you again for this invitation. So I spend most of my time as a geriatric hospitalist, where I'm meeting most of my older adults for the first time in the acute care setting, the emergency departments, the hospital wards, or in the ICUs. So I'm going to walk you through my workflow in terms of assessing how to assess these older adults and guide some clinical decisions. I hope to provide you with a framework to have some of the more critical conversations, a review, some recommendations for palliative symptom management, and finally, some suggestions on how to better engage palliative care support in your health system. Next slide. So we know that older adults represent a heterogeneous population, many of them living, as we've heard before, with multiple chronic comorbid conditions, Because of their advanced illnesses, they're on a number of different medications where polypharmacy and adverse drug events become a concern. They're also often tackling baseline physical limitations, cognitive impairment, and have varying thoughts in terms of their goals and preferences as to what matters most. Over the past several years in the geriatric community, we've seen the dissemination of something called the Geriatric 5Ms, which collectively capitalizes on all of these issues: the multi-complexity, medication, mobility, mentation, and what matters most in older adults. In light of the COVID-19 pandemic, I think it's super important that we understand and bring what matters most to the forefront of a lot of our conversations. Next slide. I thought I'd share with you some tools that I think become helpful as I think about our patient population and using the 5M model. For emergency providers, my hope and my wish was that a lot of these conversations are happening before our patients land in the emergency department. But the first tool that I think is important to recognize if your patients do have is something called a MOLST, or medical order for life-sustaining treatment. Some states, this is often referred to as a POLST form. The MOLST form is intended for patients with serious health conditions. It gives us a guide based on their previous discussions on preferences and goals and values for those who want to avoid or receive life-sustaining treatments, those who reside in long-term care facilities or require long-term care services, or those patients whose prognosis are presumed to be less than 1 year. It is a way of documenting what the patient's preferences are for cardiopulmonary resuscitation and intubation, as well as more advanced discussions on life-preserving treatments. In our institution, this is a form that's often being completed by our outpatient providers. This is a form also that if I'm caring for a patient, it's updated after a hospital admission. And it is from our community partners, patients coming into the hospital from our local nursing homes and assisted living facilities. This is a form that is often transported with them. So it may be useful to help guide clinical decision in the acute care setting as patients are coming in with the COVID infection. Next slide. The other tool that I find extremely helpful in the acute care setting is something called the Clinical Frailty Scale. For many of our older adults, we know that function really predicts prognosis. The Clinical Frailty Scale is a 9-item pictorial scale, which walks you through who our patients are, those that are very fit and robust, those that are vulnerable, those that are frail, and those that can be terminally ill. I use this in the acute care setting to help guide complications that can be anticipated with a hospitalization. It helps predict length of stay and discharge options. It's also been shown to predict survival for some of the oldest of old in critical care units. I use this, the MOLST, and the Geriatric 5Ms, and what matters most, to help guide some clinical decisions when we're meeting our most frail patients. For many of our older adults with multiple complex comorbidities, and those that we've already heard are the highest risk for poor outcomes with the COVID-19 infection, I think it's important to consider these 3 assessments in addition to some of the more objective prognostic indicators such as the SOFA scores and the ePrognostic Walter Index, which help give us some information on older adults. Next slide. Now, the truth is, I know it's very difficult to have in-depth conversations about goals of care in the emergency room when our patients are coming in so acutely ill, that there's time constraints, and that they have rapid changing clinical status. However, a lot of this does fall on the frontline providers, and when possible, it's important that you use a more structured framework and stepwise approach to approach these very difficult conversations. What I've listed here is a framework that's been helpful for me, and this is what I learned during my training in terms of using the guide of a remap framework. This allows us to address late goals of care conversations when decisions are imminent. And as I walk you through it, it allows you to, one, reframe what's going on with your patient in front of you. What's the big picture? What things need to be changed and why things are different. Ease for expecting the emotion and how to best respond to with an empathy statement. Then to map out what's important, hopefully align with the patient's values, and finally plan treatments to match these values. The nurse statements on the right side of the screen, help us name those emotions and better articulate those empathy statements. Name, meaning sort of naming what you're observing with your patient. You seem upset by this news. Understand, showing respect, support, and exploring what's important with the patient and what they've understood by your discussion. The S here is for silence, because often in these conversations, it's hard to find what to say, but silence is okay. Next slide. In the recent weeks, as we've learned more about the COVID-19 pandemic, our leaders in the field of communication and in palliative care have been actually developing scripts to help guide some of these difficult conversations for those high-risk patients that are landing in the ED where we need information quickly. This allows us to this provides us with the dialogue and language that can be helpful to get the questions we need in a timely manner. As we walk through it in terms of checking in with the patient, asking what they know about COVID, and hopefully identifying healthcare proxies and understanding if they know what's important in terms of their goals of care. Again, there's a decision point after you elicit their emotions, but also a decision point in deciding which direction these patients may go. I will recommend reviewing some of these websites, the Vital Talk website and CAPC, as these scripts have been, are currently being updated and evolving very quickly to help guide providers with any direction these conversations may go. Next slide. So I'm going to switch gear and just touch a little bit on some recommendations for palliative symptom management. I know this is a busy slide, and we've heard before that most of our patients, especially older adults, tend to present atypically. But with this COVID infection, still the most common symptoms that we're looking out for are symptoms of dyspnea, anxiety, and agitation. My approach often for older adults is often non-pharmacological first. So options you can do with the patient at the bedside is having them sit upright, practice mindfulness in terms of breathing exercises, and if available, an electric fan can often help with the symptoms of dyspnea or breathlessness that we see with severe illness. When you need to switch to pharmacological interventions, opioids are often the treatment choice for refractory dyspnea. What I'll highlight here are two medications that are often used for end-of-life symptoms, morphine and lorazepam, which often traditionally we think of potentially inappropriate medications for our older adults. Morphine, despite its nephrotoxic effects, and lorazepam, which is often associated with paradoxical agitation, have both been very effective treatments for patients with serious illness and for symptom relief at the end of life. It helps treat the pain, the work of breathing, the anxiety and agitation. In terms of looking at how to dose medications, the right side of the slide offers you some quick tips on opioid management. The mantra often for older adults is to start low and go slow, and this is true certainly as we're starting opioids and benzos in the ED. It's also important to think about the pharmacodynamics of these medications, the time to peak effect, and the duration of action. So our oral regimen often take 30 to 60 minutes to take peak effect. IV medications will take peak effect a little bit quicker, between 5 to 15 minutes. And you have the option to dose every 1 to 2 hours for IV regimen for treatment effect. If you're starting an opioid regimen, as a geriatrician, we often like to add a bowel regimen. And the chart on the bottom gives you some indication of how to dose convert between the different opioids and PO and IV formulations. I would suggest also working with your ED pharmacy, your and your local pharmacist to make sure you're prescribing appropriate doses for our older patients. Next slide. So my last slide here are some thoughts on how to engage palliative care support in your institution and in your health system. I'm going to review what we've done here to try to address the clinical needs during this pandemic. The first step is that, as I mentioned earlier, we're hoping that these discussions are happening before our patients arrive to the emergency department. We've partnered with our primary care doctors, our geriatricians, our cardiologists, our family practitioners to proactively reach out to these patients, identify their most high-risk patients, and have those phone calls and document goals of care in the setting of this COVID infection. Now we also have the opportunity to complete the MOLS form electronically, so it's available in the electronic medical record. For patients whose decisions are more comfort-oriented, these providers have the opportunity to provide them with support packs and medications and appropriate referrals to community-based palliative care or hospice if appropriate. The next issue to address that can help support our patients during this difficult time is this concept of social isolation, especially for older adults. We understand the risk of putting patients in isolation. We're often donned in protective gear. This can be very frustrating for our older patients. They're in their rooms alone and isolated. At our institution, we were able to partner with IT and secure over 24 iPads that we have been able to bring to the patient's room and connect them with families and help facilitate goals of care conversations at the same time. And finally, really tapping into the palliative care experts for these difficult conversations when we can. Our system has been able to launch a 24-hour phone access to providers and a separate line for families who need more aggressive or intensive palliative care guidance. We've also moved and mobilized our team to have presence of palliative care physician within our ICUs, our COVID units, and in the ED. Certainly, a lot of these frontline conversations requires all of us to be comfortable in having some of these difficult conversations, but recognizing when we can get help is also extremely important. Next slide. I think what we've learned so far with this pandemic is that we're entering very uncertain times, and our patients, our health systems, and our communities need all of our expertise as physicians. So I end here with this quote to remind us why we do this work, which is truly to cure sometimes, treat often, and comfort always. And with that, I can answer questions.
Good, thank you very much, Martine. And to everybody else who participated, it was an awful lot of valuable information transmitted rather quickly, sort of similar to what's happening around us on a daily basis. I hope that everybody has an opportunity to open the chat box. There's been an awful lot of interesting comments coming in, some specific question, quite a lot of resources. We'll try to capture that and include it in the information available afterwards. But for the moment, I'm going to turn this over to my colleague Eula to start the questions back with the first group who presented. Eula, are you online?
Yes. Can you hear me? Can you hear me?
Yeah.
Okay, great. So again, want to thank everyone for the great questions and the great discussions. I don't know if we're going to be able to get to everyone. I've been trying to track all of them. So we're going to actually focus on some targeted key questions. Actually, I think the first I'm going to ask, is going to be directed to Adam Perry and Mike Malone to talk a little bit and comment about questions around nursing home and long-term care facility patients. I guess if there's anything that you can help really bring some guidance specifically around their transfers I know that you recently came out with an issue, and I think there are things there that you can highlight to the group, specifically about whether or not patients should be tested for COVID, and then also the concerns about what to do with these patients in terms of transferring them back. I think we got some good guidance, but I would love to hear some more detailed directed questions there from maybe Adam first and then Mike afterwards.
And Adam,
Sure.
I'll jump in after you in regards to resources if you want to cover some of the concepts.
Okay. Thanks, Eula. And that's a great question and really very timely in that there have been joint recommendations just, I believe, yesterday from post-acute and long-term care and assisted living organizations with regard to this sort of conflicting incentives, unfortunately, between hospitals and assisted and skilled facilities. So a few key points to keep in mind. First, there are 15,000 Starbucks in the country, and there are 15,000 SNFs and 30,000 assisted living facilities. These assisted living facilities often don't have any medical oversight with a physician on staff. They have, in the best of times, they have a scant staffing, scant PPE, scant ability to isolate anyone with respiratory symptoms. Skilled nursing facilities are in the same boat, but have some medical oversight. And we also know that COVID is devastating in congregate living facilities with functionally and cognitively impaired older adults and frailty. The numbers coming out of the index place in Washington are currently 36% mortality with infection. The recommendations have been evolving. CDC requests or recommends that older adults with suspected or confirmed COVID can be discharged from an emergency department or nursing facility or from a hospital to a nursing facility that can properly isolate. And that's really the key concept here. In response to that, states have had their own recommendations. The hardest hit states, California and New York, are siding with the CDC that yes, you can send home patients who don't need hospitalization without testing. And other states like Florida have said that perhaps you should hold people pending testing so as not to introduce COVID into the facilities. So there are the federal, state guidelines that differ, and then you have a professional organization that says, this is very dangerous and maybe we should think about it. So I would urge you, in that there's no real clarity around recommendations and they evolve daily, to communicate with your referring facilities. Understand if their capacity to work with and isolate people who are suspected of COVID. Try to find the providers who are going to be in charge of coordinating their care after the emergency department and work with them. And that's part of what we're talking about with the transition slides. Because with 45,000 facilities in the country that are caring for functionally and cognitively impaired older adults, the chances that they'll land in your emergency department are escalating. And really the answers seem to be local right now. And communication, we think, is key to that. I hope that makes sense. Mike, I'm sure you have a lot to add.
Thank you very much, Adam. I'm just going to jump in. We really do have only 4 minutes left, and I want to make sure that everybody has a chance to participate. There were a couple of very specific clinical questions for Kusum, Dr. Mathews. One was around some hospitals have basically prohibited BiPAP. What do you think about that? What are the targets for oxygenation that you feel that we should be aiming for? And do you have anything to say about the definition of fever in geriatric patients in particular?
Let me start with the last question first. I think aiming for a 99 to a 101, especially if there are other concurrent symptoms or sick context or history that suggests COVID, that's the patients that I'd be more concerned about. And even more so if they have other comorbidities or frailty that puts them at risk for the negative sequelae associated with COVID-19 infection. These are the patients that may be a person under investigation, a PUI, until that COVID swab comes back. But these are the ones that I worry about the most because they're the ones who will go home and then unfortunately have a terrible outcome when they're left by themselves. The second question was about the target oxygen. We're shooting for 92 to 96%, not going too low based on some recent studies in non-COVID patients. And again, you can have an isolated hypoxemia. It's really the work of breathing that helps us decide who will need additional therapies. And then finally, the last question about BiPAP. So this is institution specific. I think BiPAP, especially if you are making sure you have a good seal and you have a good RT staff, enough RTs to verify this. And again, negative pressure, it is a modality that can be used to stave off intubation in certain patients, especially in our patients who, some of which are DNR or DNI. It is actually good to think about other modalities because we don't want to just leave them in a state of respiratory distress, and having help with their work of breathing can often be also comfort oriented.
Good. Thanks a lot, Kusum. And my final question that we're going to have time for is going to go out to Martine. There was a lot of chat in the box around discordance between previously recorded advanced care plans using either a POLST or a MOLST or something, and current, and whether those previously recorded wishes reflect current reality. Any comments about that and how an emergency physician can address it?
Thank you for the question. And that is a great question, and it's a very real one that we're also seeing. I mentioned this proactive approach of reaching out to our highest risk patients. But in light of it, we've actually seen a lot of patients also request the opposite, to rescind their previous DNR, DNI with the hopes of treatment in the acute care, for this acute infection. So again, these are all difficult discussions. I think the goal is to treat patients and align with what their decisions are and goals are at the time. But it is a reality. I think everyone has that autonomy to decide what they want. They also have the ability to rescind previous discussions.
Good, thanks very much. Eula, any last comment or question, and then I'll wrap things up. Eula, you're still on mute.
No, I wanted to really commend the audience for a great engagement, some really outstanding and excellent questions we may not all get to. I do want to say this was a very international audience. We had at one point over 383 participants representing countries all over the world: Canada, the UK, Auckland, New Zealand, Tasmania, Finland, and many United States representatives here. So again, everyone, please stay tuned to the resources available. Please check the posting of this presentation, and the chats will be available because there were a lot of excellent links available to it. And stay tuned for your emails, because in the coming weeks, we will also be reaching back out to you with how you can access your 1 hour of CME that'll be available through ESAP.
Good, thanks, Eula. Last slide, please, Laura. So just one final thanks to our sponsors, without whom we couldn't be doing this work. And a reminder about the GEDC website. All of the resources that you've heard about today are currently available on our website, and we'll be posting lots more as time goes on. Thanks for being interested in this topic. It brings a whole new light to providing excellent care to older people in emergency departments. It's our new reality, and I hope that we've been able to contribute to your understanding around the globe. Thank you very much, everybody. Connor, is there any way to capture the material that's in the chat? Because I think it gets lost once we end the meeting. You're on mute.
You're on mute, Connor.
So it's automatically recorded when you use the webinar function. It downloads it so we can include that on our, we can go through it and include what we want. I kind of collated all of the links from the